Thank you, Sam, and welcome to everybody. Really appreciate the turnout. Last year, I don't know, hopefully everyone in the room is aware that CMS or Medicare actually okayed reimbursement for patients with peripheral arterial disease in a supervised exercise setting. So I was very hopeful that we'd be able to put that topic on our agenda. And I'm very pleased that we have a very well-versed speaker who's here with us today. So Dr. Arman Kumar is a board certified in cardiovascular medicine and echocardiography and vascular medicine. He's currently a cardiologist and a vascular specialist at Brigham and Women's Hospital at Harvard Medical School. His research interests include conducting randomized clinical trials for improving outcomes in patients with atherosclerotic vascular disease, diabetes, and obesity. With that, he's contributed to over 45 scientific publications, and he is currently a research fellow on the TIMI study group. His clinical interests include management of peripheral arterial disease, coronary artery disease, aortic aneurysms, aortic dissections, and venous thrombosis. So please join me in welcoming Dr. Kumar today and for a very, hopefully, insightful and enlightening talk.
Thank you. Thank you very much. Appreciate the opportunity to come and talk about this a very important topic. A lot of times, usually, when it comes to cardiovascular disease, people are talking about new devices or new drugs. But I think exercise or improving someone's functional capacity is a very important thing, and it has so much of an impact that we can do, both psychologically and then also overall in the overall outcome of the patient. But before I start my talk, I just want to get a sense of, so if you could raise your hand, how many of you have participated in the improving the functional capacity and overall outcome of patients who have PAD? Okay, that's a good number. And how about cardiovascular disease? Could be cardiac rehab for MI and heart failure. Okay, perfect. No, great. So today, what I want to talk about is exercise therapy in patients with peripheral artery disease. Now, as you know, currently both in the United States and throughout the world, cardiovascular disease, with that I mean MI, myocardial infarction, stroke, and heart failure, and also peripheral artery disease, they are still the #1 killer, also the #1 cause of mortality and morbidity. Now, compared to last 50 years, we have really made dramatic progress. Now, I will share with you, 50 years ago, the treatment of heart attack used to be closing patients in a dark room and giving them sedatives and asking them not to move around. But we have really made good progress. Again, even patients who have heart attack, we're able to get them out of the hospital very fast. Now, how is that important for peripheral artery disease? When I look at a patient with peripheral artery disease, I think of them as the most advanced case of cardiovascular disease or coronary disease. Now, as you know, coronary disease happens because a lot of risk factors like high blood pressure, smoking, high cholesterol, diabetes, sedentary lifestyle, and because of that, patients develop blockages in their heart arteries. Now, when that becomes really an extreme case, when it becomes very bad, that is when patients that develop blockages in their leg arteries, and that is what we refer to as peripheral artery disease. Now, how big of a problem it is? Why should we care about it? We should really care about it because what we know, as of now, currently in the United States alone, 8.5 million people have peripheral artery disease. If we look at the worldwide population, it's close to 200 million. Now, how do we know? These numbers are coming from people who go to physician's clinic or they're going to different healthcare facilities, and they get a test called ankle brachial index. That test may not be familiar to all of you. So in brief, what the test really involves is checking blood pressure in the upper arm, could be right or left, and then checking blood pressure in the lower extremities, and then seeing if there is a difference. Usually, because of the effect of gravity, the blood pressure in the legs or the lower extremity is higher compared to upper extremity. But when we see that the blood pressure in the lower extremity is lower compared to the upper, that is when we think that it's bad. And usually for us, we look at that ratio of less than 0.9 to be a cutoff of calling what peripheral artery disease is. Now, I think that number of 8.5 million in the United States is underrepresentation, because I think those numbers are really coming from people who are symptomatic or they're getting surgery or their stents put in for peripheral artery disease. I think in the community, there are many people who have peripheral artery disease, but we just don't know. And why do we don't know? It's because what happens is that when you develop peripheral artery disease, the leg starts hurting. And what people do is they just start cutting down on their exercise capacity. You know, people, they used to work out in a gym, they used to run. From running, then it becomes just brisk walking, and then after that, it just becomes being sedentary. And a lot of people then, as you know, this is mainly a problem of aging population. A lot of people think that, oh, you know, probably this is just my age. And then because of that, you know, it goes under-recognized. And like I mentioned earlier, these patients, they have cardiovascular disease too. What happens is they have a heart attack, they probably die, and no one discovers that they really had PAD. So the take-home message is that PAD is really a problem, and this starts showing up as a problem when people, they start crossing age of 50, and that is consistent with what it is for other forms of cardiovascular disease. Okay, so with that, I just wanted to share with you that we really care about this problem. Now, if we look at the prevalence trends of peripheral artery disease, so this is a data here from the American Heart Association. On the y-axis is the prevalence, that means what percentage of the population has peripheral artery disease. On the x-axis is different age groups. Now, as you can see, when we start from an age group of 40 to 49, and then we move to the right extreme of more than 80 years of age, the prevalence of PAD overall is increasing, right? And again, as you know, like if you were to go back to 30 or 40 years ago, people didn't make it. I mean, very few people lived to that age. But now I think, well, it's all good news that we have therapies, the cancer treatment that you heard about this morning, and then all the advances overall in healthcare has made people live a longer life, right? So because that people are living here, maybe in the past they lived here. Now, since you're with living longer comes a lot of problems. So with that, I mean cardiovascular disease, PAD, cancer, other things. So the bottom line is that the prevalence of PAD now is increasing. So we'll be seeing a lot of patients who need our help. Now, the different colors here also, as you know, overall, we can't generalize anything, and so is access to healthcare, and so is how they do in life. So there appears to be, if you look at the racial differences, especially with our Afro-American patients, the one that is in the red, and then again with American Indian patients, they seem to be probably with, because of poor access, and then you know, they, or because of some genetic predisposition, they are again our vulnerable population, so at a higher risk, so we should be thinking about that too. Okay, so again, as we talked about that cardiovascular, coronary heart disease and PAD, they overlap, they have a lot of things in common. So what are the risk factors for PAD? The number one risk factor that we think here is smoking. So if you are a smoker, if someone was a smoker, they're at a threefold higher risk of developing PAD compared to patients who weren't. Diabetes too. And I think this is particularly important because, as you know, diabetes and obesity, high cholesterol and hypertension, a lot of times are clustered, they interact with each other. And we know that the prevalence of diabetes is increasing at an exponential rate. So again, if you have diabetes, you're at a threefold higher risk of developing the PAD. Aging, so with aging comes increased risk of PAD as it is for coronary heart disease. And other risk factors like high blood pressure, coronary heart disease, with a recent epidemic of substance abuse in the United States, again, use of drugs, or which could be either anything like marijuana, cocaine, or any illicit drugs, the risk of PAD just increases. So you just have to keep that in account too. And the reason why I showed that over here is that when you have PAD patients come up to you for exercise therapy, you have to recognize that these are the risk factors. You know, we can do a lot of work with medications and with exercise, but if we don't address these problems, it will keep coming again and again. So we have to address these when we see these patients. Okay, now I'm sure, as it is in your field, that you know what form of rehabilitation or exercise therapy or what pattern is ideal. They're all driven by a lot of evidence, and evidence comes from clinical trials or it comes from observational studies. So in the field of vascular medicine and cardiology, a lot of this is driven by clinical practice guidelines. Now, why it is important to look at clinical practice guidelines is not just because it includes a lot of people who come from the different field, but also because the insurance companies, the regulators, and the payers, they care about it. So if there is something that you think works, it's very good. But if the payers are not ready to pay for it, then again, you know, it's not helpful. So that is why it is very important to see what the guidelines says and where their evidence is coming from. So for you to know, in 2016 is when the most updated version of the PAD guidelines came. So this guideline tells us how to treat PAD, what is good and what is not good. Now, again, the guidelines tells here in this particular slide that if we are concerned that someone has PAD, the best way to screen or to test for it is to do an ankle brachial index test. And again, the reason why that is important is that that is something that you can do in your clinic too. So for example, if you have a patient who has a coronary disease and after a heart attack comes into you for cardiac rehab, and then they're saying that, oh, I'm doing fine, the heart procedure went well, glad that I'm alive after having a heart attack, but my leg hurts a lot. Okay, or when you're having that patient exercise on a treadmill, they're like, yeah, my chest pain and the shortness of breath is not there, but just my leg keeps aching. Now, if you didn't know that PAD is a problem, you would just think that that may be from arthritis. But really, no, if they had blockages in their heart, they could probably have that there. And it can be very easily tested by checking blood pressure just in the upper extremities and the lower extremities. And all the facility has a blood pressure cuff. And again, it can be done very easily. For measuring ABI, it's just a typical cuff in the right upper extremity. And then the other can just be a typical cuff. Again, if someone is not very overweight and doesn't have a lot of gut, that you can put around the ankle. So ABI stands for ankle brachial index. Ankle because you're putting a cuff at the ankle, and the brachial because you're occluding the brachial artery in the upper arm. So again, the guidelines tells us that just do that test, and if the ratio is less than 0.9, then it is very likely that the patient has PAD. 0.9 to 0.99 suggests more of a borderline number. But again, not all most patients with PAD would have this number less than 0.9. But in a rare situation, if they were to have kidney disease or diabetes, then again, they might have a false negative test. So again, just to keep in mind that this is not a 100% accurate test. But again, considering that this is a non-invasive test, it can be done very easily in any facility. One thing also I want to tell you that is the lower the number of ABI, so the y-axis over here tells us the risk of dying from a heart problem. X-axis tells us what the number is from that measuring that blood pressure. Is that the lower the number, the higher is your risk from dying of heart disease. And in a rare situation, a higher number. And again, those are patients with bad diabetes and kidney disease that you are at a higher risk of cardiovascular mortality. But usually a number around 0.9 to 1 means that they're going to do well overall. Okay, now the guideline tells us how to treat PAD. The guideline is telling us that in terms of treating PAD, you have to give them blood thinners. You will see that when you will have a lot of patients who have PAD and they're coming to see you for either cardiac rehab or for exercise therapy for PAD, they would be on either aspirin or clopidogrel, comes with a common name of, or the name for this is Plavix. So we give them these medications because these medications protects them from having a heart attack, protects them from having a stroke. But also, as you know, a lot of patients with PAD, if they have blockages in their leg arteries, like it happens with heart attack, those plaques might just rupture suddenly, and then they might have complete blockage of their leg arteries, and that is what we refer a term called critical limb ischemia, acute limb ischemia. The reason why I mentioned that is because when these patients come to you for exercise therapy, you might see these terms in their charts. So think of PAD as just parallel form of CAD or coronary artery disease. So coronary artery disease, a lot of these patients for a long time, they would have these blockages. And when these blockages, they keep progressing slowly, that is when they develop chest pain with exertion. In PAD, think about it the same thing. They have blockages where it gets worse. Usually in the leg, we are thinking about a blockage more than 50%. Then they slowly will start having claudication. Claudication means developing pain when they are walking. Now typically, the word typical claudication means that you are having pain in your calf or in the thigh when you are walking. But we have noticed that only 1/3 of the patients who have PAD have those blockages. They have the typical symptoms. The other 2/3 would have atypical symptom, which we refer to as atypical claudication. And in that case, the patient would complain to you of, the pain in the buttocks or the lower back pain. Now, the reason why I say that is, imagine someone coming to you for cardiac rehab, and if that patient is complaining to you of, oh, I have this lower back pain whenever I'm exercising on the treadmill, don't think that it's from their arthritis in the back. It could be because of PAD, and that is why I think thinking about PAD is very important. Now, I'm just trying to here, I interrupted a little, deviate a little to show the parallelism between PAD and CAD. Now, patients would have, claudication is parallel to having stable angina. With exertion, I have chest pain. Now, what can happen is that these patients, they might rupture their plaque. And now why these plaque rupture? Because of high blood pressure, a lot of smoking. Some, we don't know why, because of stress. then if that plaque ruptures, then some of these patients might have acute blockages. Now, the acute blockages, the sudden rupture or the acute blockages causes heart attack, but in the leg, it causes acute limb ischemia or critical limb ischemia. These are the patients who would say that, you know, I used to have pain when I was exerting, but now I have pain at rest. Or suddenly my leg is getting pale. These are the patients, like for heart attack, when someone is sitting having chest pain at rest, you ask them to go to an ER, you rush them to an ER, because these patients, if they do not get those blocked arteries open in their leg, they would require amputation. So pretty much everything is just parallel to what is happening in the heart is now happening in the leg. So we have to respect both of them. So the aspirin and the Plavix helps with that. Statins are a medication that lowers bad cholesterol as it protects you from heart attack and stroke. It also protects you from trouble in the leg, causes the plaque to regress, and also protects you from having progression of these plaques. Blood pressure control is recommended for PAD, like you would do for any heart disease patient. These days, really, because of new guidelines, now we are aiming for a blood pressure goal of less than 130/80 for all patients. So even for your patients who are coming for cardiac rehab, goal is now less than 130/80, and the same is for PAD patients. Smoking cessation is the key. And again, I'll be very honest with you, that when I chat with my patients, they tell me, again, it's hard to quit. I mean, it's very hard to quit any habit, right? For example, if you're a coffee drinker, and imagine if someone did studies and found out coffee is bad, and someone wants to ask you to quit coffee, it is hard. So that is why, again, it takes a village. So don't give up on your patients. Talk to them. Again, at times, in the early part of my training, I used to get frustrated when I used to tell them, this guy had a heart attack, and he's still smoking. But then, you know, after chatting with these patients, I realized that it's tough. So you have to really work. It will be slowly. So I think the key here should be that, and again, I'm sure you're chatting with your patients about that when they come for cardiac rehab, is that, you know, like to, of course, tell them about quitting, but also important to tell them that, hey, you know, if you smoke 10 cigarettes a day, just cutting it down to 5 will help. And then you go down. I think it's very hard for these patients to go from 10 to 0, but maybe not that hard to go from 10 to 8 and then slowly down. And there are medication that you can give to these patients for smoking cessation. So, you know, talking about smoking cessation is very important. I cannot really overemphasize that, you know, how important it is to control their blood sugar. And again, the reason why I'm talking about, again, we'll talk a lot about exercise too, but the reason why these things are important is that these patients are going to spend a lot of time with you, and they'll be telling you about that my blood sugar is not under control and all that. And then the key thing is to reinforce and say that it's very important to control your blood sugar, and I think that will help. Now, currently for all CAD, heart disease patients and PAD patients, we are recommending that they all get flu vaccinations every year. It's very important. Okay, now coming to, you know, the other important thing, the most important thing that we'll be talking today is, what do the guidelines tell us about exercise therapy? Now, again, the guidelines time and again have been telling this again and again, that for patients who have claudication, a supervised exercise program is recommended to improve functional status and quality of life, and to improve their leg symptoms. And again, when the guidelines come out based on how strong evidence we have, they would give different color. So green color, whenever you're looking at a guideline, means that we have strong evidence, we should do it. Yellow means that, yeah, most of the evidence, they suggest that we should do it, but again, it's not as strong as a green one. And red means that, oh, the therapy that we are mentioning causes harm. So for supervised exercise therapy, it has always been a green light. They also say that a supervised exercise program should be discussed as a treatment option for claudication before possible revascularization. So before the doctors are thinking about putting in a stent or doing a leg bypass surgery, they should address clearly. And again, when it comes to reimbursement purposes, like if I have to talk to a patient, or if I have to send our charts for reimbursement to insurance company for putting in a stent in the leg or for bypass, we have to clearly state it that exercise therapy was tried, and despite that there was no improvement in symptoms, or this patient could not go through exercise therapy because of these problems. Because if we don't do that, you know, you might put in 3 stents in the leg, you are not getting reimbursed. And I think that is good news, right? Because again, I feel that less is more. So if we can help patients with things that does less harm, then why not do that if that can help? So the guidelines, again, reinforces what all of us believe that in the room. Now, The guideline says that it is also helpful that in patients with PAD, a structured community or home-based exercise program with behavioral change techniques can be beneficial to improve walking ability and functional status. Now, what they're telling us is that, okay, we are giving a green light, like it is for traffic, that, okay, completely go, that, you know, if you don't have opportunities for, or if patients are not interested, or if you don't have infrastructure for supervised exercise program, then it is okay to do these things in a community setting, or to do it at even home, and you know, with instructions being given over phone, or if you can make videos and things like that. They say that, you know, you can always do that too. Now again, this is preferred, but again, because of some limitations, then, you know, if we can do this, this is fine too. Now, they also suggest that in patients with claudication, alternative strategies of exercise therapy, including upper body ergometry, cycling, and painful low-intensity walking that avoids moderate to maximum claudication while walking, can be beneficial. So if we can do this, you know, even this would be fine. But again, the top one is preferred. And again, the reason why they are saying that this should be fine is because I think a lot of these patients might have other comorbidities. They have heart failure, or they have bad coronary disease that cannot be fixed with stents. But they say that even that, again, some form of exercise compared to doing nothing is always helpful. But the more the exercise that we can do, the better it is. Okay. Now, the key is to understand that how would exercise help these patients? Because a lot of people might say that, you know, there's the blockage there, and you know, how will the exercise really help? And so we should just go ahead and fix it. No. See, we have to understand that when patients, they have blockages, there is reduced oxygen delivery to that area in the leg. And these patients, a lot of these patients, only blockage is not the problem. There is problem with endothelial dysfunction. With that, I mean that there are a lot of cells that in the leg. So as you know, the blood comes from the heart, it goes to the blood vessel, and the blockage decreases the blood supply. But even if you improve the blood supply, if the cells that uptake oxygen, if they are not good, then again, you know, you might see that the blockage is open, but the cells are not doing a good job. Patients are not going to feel fine. And these patients who develop PAD, they have had this bad humor for a long time. A lot of free radicals, a lot of bad cholesterol, and a lot of high sugar that has been circulating and created a toxic environment in their body for a long time. So that is why exercise might help. So endothelial dysfunction, these patients have a lot of inflammation there at the end. You can see that. And because of these problems, what happens is that it's not only the blood vessel that, even though the term says peripheral artery disease, but the artery only doesn't remain a problem. The muscles are affected. There is damage to the nerves in the muscle. There is damage to the muscle fiber. And there is also abnormal metabolism in these patients. Now, what happens is when these patients, their functional capacity decreases, they become deconditioned. And then because of that, they end up developing other risk factors that it just becomes a vicious cycle. And then, you know, these patients are worsening obesity, high blood pressure, high cholesterol, high sugar. And then it's just that, you know, this charade just keeps continuing and continuing. And that is why just fixing the blockage won't help, and exercise therapy would be helpful. Now, let's see what exercise does to a lot of these bad things that I talked about in patients with PAD. Exercise would affect your this exercise training would improve endothelial dysfunction. There are a lot of studies suggesting that it will do that, and that happens. It will also improve ischemic reperfusion. We also know that exercise does also decrease inflammation. It also improves muscle atrophy, because when they're exercising the muscles, they regenerate, the muscle mass would increase. And then, you know, there's evidence suggesting that it also would improve the metabolism. Now, the endothelial cells, the muscles are able to utilize more oxygen, and that is why these patients feel better, and it will result in improvement in their functional capacity. And again, we note that exercise will take care of a lot of these bad risk factors too, and that is why we think that exercise will be helpful. Okay, this is a slide from the American College of Cardiology. When again, American College of Cardiology earlier, again, they had to really lobby a lot and do a lot of advocacy to bring reimbursement for cardiac rehab, which again, all of you guys are doing it and think that it helps patients. But I just want to show also that why exercise and improving their functional capacity is not the only goal that we'll achieve when we bring these patients for exercise therapy for PAD. Now, we would all agree that when patients are coming to you for cardiac rehab, you help them do regular exercise. You also tell them about adopting a heart-healthy diet. You also help them with reducing stress. You also reinforce them about doing medical therapy, and you also tell them about stopping smoking. Please raise your hand if you disagree with me, or any of you are not doing this. You're just making them exercise and telling them, okay, bye, right? You all do this. So I think, when we bring these patients for exercise therapy for PAD, we'll be emphasizing a lot of these things too. And again, when we bring these patients for exercise therapy for PAD, our goal is not to improve only limb outcomes, but to also improve their cardiovascular outcomes overall, right? Because what good are those two legs if the heart has stopped working, right? So we have to think about a patient as a whole. Okay, so wonderful. So again, as you know, we have had evidence, and I'm going to go over a lot of these evidence for exercise therapy, why we think it's important. But again, in the past, the barrier was mainly getting reimbursement and looking at the data. Now, as it happened for cardiac rehab, again, a lot of research had to be done. Now, individual trials are called individual clinical trials, but when you pool data from a lot of clinical trials, that gives you a lot of power. It's called doing a meta-analysis. Now, again, there were meta-analysis that in the past, decades ago, showed that cardiac rehab is helpful. And because of that, then payers thought that, you know what, okay. Because again, payers are just looking at one thing, and that is dollars. Now, again, they would say that we care about patients. Now, what happened was for cardiac rehab, payers realized that by sending patients to cardiac rehab, they're going to have to pay for less number of stents, less number of heart transplants, less number of defibrillators. And that is when, based on these data, they realized that, you know what, if we were to pay for this, which is a lot cheaper, then we'll be saving money in the other area. And that is when they decided to pay for cardiac rehab. And again, that is, it is very important to think of that principle when thinking about reimbursement and coverage for exercise therapy for PAD. Okay. Now, let's think about that, again, we all think that exercise is good, but again, to payers, or we have, for a lot of things, we think that something works, but we have to test it in form of a trial. And again, it has been done. So a lot of clinical trials and observational analysis has looked at using supervised exercise therapy to improve functional capacity or to improve claudication distance in patients with PAD. Shown here again, we'll go into the detail of this paper. It's a meta-analysis of several trials that looked at the benefit of exercise rehabilitations for treatment of claudication pain in patients with PAD. Now, what this trial had done was it pulled data from multiple. So each row here indicates multiple clinical trials or studies of looking at the role of supervised exercise therapy, comparing it to no supervised exercise therapy, and seeing if it would improve claudication distance. Now, again, the numbers there may be small, but I really don't want you to pay a lot of attention to the numbers. The reason why, the message that I want to convey here is that it is, so to really power or to do a clinical trial, to show that something really works, you need hundreds or you need thousands of patients. So for a lot of drugs that we test, if this drug will reduce the risk of heart attack or lower cholesterol or not, for those trials, you would have seen that those trials have an N of, or a sample size of 10,000 or 20,000. Now, doing those trials, and again, I myself, work on clinical trials now, it costs hundreds of millions of dollars to do those trials. Okay. Now, where do we get that money from? That money comes from industry, right? Because industry has, again, they want patients to do well. But again, for them, they have invested billions of dollars in developing a drug. But now to bring that drug into the market, they need FDA to give approval. And FDA would not give approval unless you do a clinical trial. So for them, it's an investment of a few $100 million. Okay. Now, why would they put in an investment? Because again, every drug company, they have investors, right? And again, drug companies, they have good interest. They want the community to do well. But again, a drug company wouldn't work if the people are not investing in that company. Okay. So they have to invest that hundreds of millions of dollars to do a trial. And when they show, when you test that in a trial setting, a drug works, and that is when the FDA would give approval, and that is when a drug goes out in the community. Now, who would pay to do a clinical trial or supervised exercise training, right? No one would. I mean, the payers won't pay and all that. So, okay. So there are a lot of people who have thought that this works, and that is why a lot of clinical trials have been done. The problem has been the sample size in those trials have been very small, and that is why it has been hard to show that there is benefit. But despite that, there are a lot of trials. They have used different endpoints. Like someone said, let's exercise for 60 minutes for 24 weeks. Someone said, let's exercise for 45 minutes for 13 weeks. And because of that, there have been differences in what those trials have done. So what we have done is that, if we pool data from, here we have 3 control trials and then 18 observational studies. And then, we have had this evidence clearly showing that if we look at, this is before and this is after from observational trials, with exercise therapy, the distance to symptom onset improves significantly, right? I mean, there's at least close to a twice improvement with exercise. The maximum duration of treatment, this is no exercise with exercise, just the significant improvement. Now over here, if we look at before and after, you can clearly see here that with exercise therapy, there is again a clear significant improvement. Now, this meta-analysis that Dr. Gardner and colleagues did looked at most trials that had 3 sessions lasting for 30 minutes, 3 sessions per week over a period of 6 months. And the endpoint looking here is, can we improve the distance that they can walk? And again, there was a clear-cut benefit there. So again, this was a meta-analysis including a lot of trials here. Now, there are a lot of other meta-analysis that has used a similar approach. But this meta-analysis just went ahead and looked at supervised exercise training compared to no supervised exercise training from trials from all over the world. So again, I started from trials from 1970s to 2011. So again, very powered meta-analysis. Again, sorry, the numbers might appear small. Maybe we can show you this figure. Clearly, what they showed was that supervised exercise training leads to at least a 180-meter improvement in maximal walking distance and 128-minute improvement in pain-free walking distance. So clearly, again, and for some might say that, oh, there is it's only 128 minutes. We want an improvement of 2 or 3 miles. You have to keep this in mind that this is just over a period of 12 weeks approximately, right? 3 months. And if you do that, and then I think if this was continued for longer duration of time, or if these patients will go out in the community and then walk more, then this would lead to further more incremental improvement in their overall functional capacity. Now, as you know, they currently, when we talk about supervised exercise training, what it really means is the patient comes in, we talk to them about modifying their risk factors, and then after that, they walk on a flat treadmill. The protocol, the main Brigham and Women's Hospital, we are working on starting that. We'll do that in partnership with our cardiac rehab people. But at the Brigham and Women's Hospital that is next to the Gillette Stadium, the one in Foxborough, we have started to do that in partner, together as part of cardiac rehab. And what that involves is patients come in, we just have them walk. And again, the treadmill runs at a speed of 2 miles per hour, and then we do that. And then mainly what we're telling the patients is, tell us when you start developing symptoms, and then after that, we ask them to tell us when we have to stop. And then, we're looking at and we are monitoring that. If the patient's really over a course of 8 minutes, for example, if they don't have any symptoms, then we can slowly go to 3 miles per hour speed. And then again, if they start developing, if they just can't do it, then we stop. But again, if they can do it, then I think right now, as you can think that if we look at it from the cardiac rehab point of view, those speed may be less, but I think this field will evolve more and more studies will be done, and then the protocols might advance, because especially now we have coverage, and we'll have a lot of those data coming on. But I just want to talk to you about that, briefly about what this treadmill walking protocol is at our facility. Now, a lot of people have thought about, okay, how about comparing treadmill exercise and resistance training in patients who have PAD and seeing, how we do with claudication distance. This study looked at 156 patients who had claudication and they had PAD. They compared treadmill walking versus exercise training, upper extremity, and then just doing nothing. And what we found here is that, again, treadmill walking compared to the control group is very good. Like, for example, you have a 36 meter walking distance improvement, but even just upper resistance training too, and provides improvement if patients can walk. So a lot of people might tell you that, oh, the resistance training shouldn't work at all. No, that's incorrect, because as I told you that PAD is a systemic problem. So I think if you have the upper body working, or if the patients are using all their muscles, then these muscles, when they exercise, they release a lot of good chemicals, and which would have effect on the entire vascular bed, and that is why we were able to see some improvement in claudication distance with just resistance training too. Okay. Now there was a randomized controlled trial done, which actually a lot of my colleagues were involved. It was called the CLEVER study. In this study, investigators looked at comparing supervised exercise versus primary stenting for claudication in patients who had aortoiliac PAD. Now again, if you were to start from like hips to the bottom, the biggest arteries or the ones that are more proximal there, it's called the iliac artery that comes from the aorta. And again, with that, if that is blocked, then again, it's a significant area that is affected from not getting blood supply. So in this particular trial, what the investigators did was, again, less number of patients, close to 110 patients who had this form of PAD. They randomized patients to optimal medical therapy alone. So just taking pills, which was telling them to exercise. I'll be very honest, if you just tell patients to exercise, most of them, they just don't do it. Because again, you have to teach them what kind of exercise to do and how to do it and when not to do it, right? And there's a medication called silostazol, which again, studies have shown that lead to some improvement in exercise capacity. See, if you tell patients to do just, medical therapy, versus if you were to tell them to take these pills and do supervised exercise therapy, or you were to do pills plus stenting. Now, stenting, the cost of putting in a stent is probably 20-fold higher than doing exercise therapy. But if you were to look at the benefit at 6 months, the real winner over here was supervised exercise training. Again, if you look at the improvement in claudication distance here, it's like 5.8, stenting 3.7, and control. Now, again, based on these trials that was published in 2012, a lot of payers, one, I had thought that they would think that, okay, supervised exercise training is great, and then, they should be reimbursed right away. But it was surprising that, again, there was a lot of reimbursement going in for stenting here, less attention was paid here. But then again, with time, people have realized that for patients who have PAD, and if it's a very bad form of PAD, if we combine exercise with revascularization, then that is when we would get the maximum benefit. And because of that, because of data here, and then, if again we look over here, that in patients, we compare optimal medical therapy. The green over here is supervised exercise. It was always beneficial. Over the course of the years, with a lot of advocacy, because of important results that the CLEVER trial showed, there has been a lot of appreciation among the regulators, payers, and physicians too, that supervised exercise training is important. And for patients who are very bad form of PAD, it is reasonable to do both revascularization, which is the red, and combining it with exercise therapy. And that is when we really would be able to, improve the quality of life and outcome of these patients significantly. Okay, so as you know, that again, supervised exercise training is great, but it has been underutilized because of many patients, many people under recognizing that PAD is such a big problem and not referring patients. So I think there has been a mistake on our part from the physicians too, and these people are not getting referred. The benefits not that appreciated. Now again, people who don't take care of PAD, they don't know about CLEVER trial data. And also, like I told you right at the beginning of the talk, a lot of these patients, they have cardiovascular disease. They just start walking slowly, and PAD is under-recognized. And also reimbursement, right? I mean, if you're not getting reimbursed, the patients don't want to pay from their pocket, and that was a major barrier. There were not facilities who could do this, but as you know, all our cardiac rehabs, I think, they're well equipped and they can do a terrific job doing exercise therapy for PAD. And then, the solution that came up was, at that time, a few years ago, the people had thought about that, okay, things may be that, doing advocacy with CMS, and some people then thought was, okay, if we can do supervised exercise training, how about home-based exercise? Now, just here, I would like to add that because of, a lot of the data coming from our exercise physiologists saying that, cardiac rehab is safe and we have really improved outcome. And then a lot of data coming from studies like Clever Trial and physicians, it was recognized that really supervised exercise training is very important. And then CMS last year reimbursed exercise therapy for patients with PAD, and because of that, even private insurers. Now, as you know, it takes it's a very lot of hard work in convincing government authorities to reimburse for something that is for private. So if CMS is reimbursing it, a lot of other payers, they are open to doing that, and they all understand that this would really have a big impact in helping our patients, and also overall decreasing the overall cost. Because if you look at the big picture, like I mentioned earlier, that we I think will be able to keep these patients out of the hospital, improve their overall outcome, and then it will be cost efficient too. So now it is CMS approved, and because of that, we've been able to now address these problems. And now more people are referring physicians. Benefits are appreciated, it is reimbursed, and facilities not available. There are facilities not available. Now, I'm sure a lot of people would ask me this question at the end of the talk, that what is the CMS requirement to reimburse? And I would just add that over here. So what CMS has said that they would cover for patients who have claudications and they have PAD, they would reimburse or they would pay for supervised exercise training to improve claudication, right? And then what they require for that is that they would reimburse it for exercise sessions, which would be at least 30 minutes, lasting for generally for close to 3 times a week for a period of 12 weeks. And for patients that you are to show benefit if they responded, and if you think that they need more therapy, they would reimburse for that too, for more than 12 weeks. What they would require for you to write is to say that the patient improved, but might require more therapy. So for those patients, again, they haven't clarified that in detail, but that would require us to talk to them, and I think they would reimburse for that too. Important thing is that what they require in terms of facilities is that it can either be done in a physician's office, or it can be done in an outpatient setup of a hospital. So these are the only two settings that they would reimburse it for. And then the reason why I say that is very important to know is that you might, over the course of the next few years or months, might hear from. So one thing I want to share with you, so a lot of PAD patients, they undergo their stenting in outpatient clinics or a lot of private practices. And I think what would happen now is that a lot of those practices would be interested in opening exercise therapy programs in their practices. So something that you guys might want to, that's something you would be able to contribute and really help these practices a lot. Because again, as you know, in a lot of areas, again, there are no cardiac rehabs, right? But if we can open these PAD exercise programs in those facilities where they have patients who have PAD who are getting their procedures done, CMS would be reimbursing it. What they want is that these facilities be reimbursed, be supervised by either, of course, it needs you, but they also require that either a physician or a physician assistant or a nurse practitioner, they have to be present there. So something to keep in mind that, some of the caveats that CMS has offered in the reimbursement. Okay, now just want to show you some quick data. So supervised exercise training is great, but in the past we used to think about unsupervised training, and there are some studies that have looked. With unsupervised training, what I mean is that you tell patients that at home, some people have a treadmill or they can walk stairs, telling people that, okay, walk this much, and calling those patients to see, did you walk, and then comparing it to supervised exercise training. There's certain meta-analysis that have been done, and it has clearly shown that supervised exercise training is better compared to unsupervised exercise training. Okay, so this is just a meta-analysis suggesting what I just said. Okay, now as you know, recently, how many of you have smartphones? Let's see. Okay, pretty much everyone, right? Yeah. Now things have changed what it was before iPhones and other smartphones came, and now I think it is very much possible to keep our patients engaged by developing apps. Like for example, I myself have an app in my phone or in my stopwatch that will tell me how many steps I've taken. So in the hospital, for example, I try to avoid taking elevators, and then, like for example, I have a goal. Now, when I'm not going to the gym, then I want to do at least 10,000 steps a day. So, it tells me, and if I haven't achieved that goal, then I would just quickly take a couple of rounds of stairs and all that. So things have changed, and it is good. So I'm sure a lot of your patients, they have iWatches and they have iPhones. So because of that, it was thought that, oh, okay, how about we use an approach in which we give patients exercise prescription, in which we tell them that, watch out these many steps, and we remind them to do that by giving them phone calls, compared to telling patients that, okay, exercise, but not doing it with the help of, using an app or using telehealth. This was tested in this trial that some of my colleagues at Northwestern had done, and then this trial was published. So in this, what they had done was they had looked at this trial is called the HONOR trial, and what they had looked at the effect of a home-based exercise intervention of a wearable technology and telephone coaching on walking performance and peripheral artery disease. So again, they had close to 200 patients. And what they had done was these patients would have wearables, and they would be given a goal of taking these many steps a week, and then they would be getting phone calls and 3 times a week, and then telling them that, okay, did you walk? And if not, then telling them keep walking mainly, and then to other groups just asking them how much you walked. Okay. Now, what they then did was over here, again, all these patients with PAD, and then home-based exercise involved 4 weekly sessions for 1 month, structured phone calls with a coach, weekly first few months, then spaced out, and then they were looking at what they're walking, and then looking at wearable activity monitor, and then seeing how much they were walking. These patients were actually doing 5 days a week, 10 to 15 minutes, and progress to 15 minutes, and they were walking until severe discomfort. And the other group was just usual care, and they looked at change in 6-minute walking distance. And again, these are just the baseline characteristic, which just shows that a lot of these patients have tons of comorbidities. Importantly, as you can see, 80% of these PAD patients had close to diabetes, some form of smoking, so they would do either current or former smoking. A lot of burden of coronary disease too. And let's see if so what they found was that just by doing telephone coaching and wearables compared to the other one, did not lead to a significant improvement in their walking distance. And what we interestingly saw here was, and also there was no impairment in the overall outcomes. So the important thing that I want to show here is that the take-home message is that using an app-based or a telephone call-based exercise training, which is at home, compared to the usual just telling them to exercise, doesn't lead to any improvement in the walking distance. And a lot of people might think that why. So what we noticed in this was the other group which didn't have a wearable, but they were just receiving a phone call a week to ask them, are you exercising? They actually exercised more. And because of that, there was no difference in the wearables. But I think for us, the take-home message over here is that we really need to complete supervised exercise training for all these patients. And then after that, I think for long-term for their life, I think, telling them to use wearables or like a coaching and other forms might be helpful. So I think, because a lot of your patients who might say, I don't want to do supervised exercise training, and can I do wearables and all that, we should quote this trial and say that there is not much benefit, and you really have to learn what to do and undergo a formal supervised exercise training before we can really get you out and then and then exercise on your own. Okay, this is some more data. So I think covered that there. Let's see, that's just okay. And this is just one last conclusion, saying that for patients who can do a treadmill-based exercise training, just ergometry or upper arm exercise, some form of exercise is just helpful, and just keeping the muscles running and keeping them active. The reason why I say that is because a lot of your patients would have heart failure, other comorbidities. They can do a treadmill-based test, or they would have bad arthritis. Doing just upper body ergometry might be helpful too. Okay, so overall, my take-home message here is that we need healthy legs for a happy heart, right? I mean, if our patients, they just can't walk and they're very debilitated because of their PAD, I think we will not be successful in our goal of decreasing the pain and suffering from cardiovascular disease. So I think the leg and the heart, they both talk to each other, and they are both very important. And then, perfect. So with that, I would be very happy to take questions.
Are certain lesions more amenable to, so you do an ABI, a segmental, are certain lesions more amenable, or certain disease to training versus percutaneous intervention?
Right, I think that's a great point. So the question was that, are certain lesions based on, where the blockages in the legs are, or what the test, which is called a segmental pressure, looking at pressure in the different areas of the lower extremity, can they tell us if exercise training may be more helpful or less helpful? I think that's a terrific question. So I think all patients, irrespective of where they have blockage, they are going to benefit from exercise training. Now, it's the other way around. There are certain blockages that cannot be fixed with revascularization. With that, I mean that if there are blockages that are too far out in the legs. What we have also recognized is that, as you know, when we look at our vascular bed, it's like a tree, right? You start from the bottom when it's very wide, and that is how the arteries are. But as you go to the branches, then they keep getting small and small. For patients who have PAD, the disease affects all of them. Of course, if you have a tight blockage in the proximal, in the bigger branches, then the smaller branches are not getting blood supply. But imagine if you fix the bigger branches, but the smaller branches are not doing well, then in that case, the muscle and the nerves from which the pain and the suffering comes, they're not going to see that oxygen. So completely recognize if they're very tight blockages, they have to be fixed. But I think the exercise therapy, which has a systemic effect, it's like taking a pill. Like, for example, when you take a baby aspirin, it goes to your belly, dissolves, and then the good effects, it just travels to all. I mean, these drugs, they are small molecules. They can seep into those small capillaries and give you the good effect. And the same thing happens with exercise training. When you exercise, a lot of that good chemicals are formed, and those good chemicals, they neutralize the effect. The second important part is the brain, heart, and the leg. I think they all talk to each other. I think with exercise, what you're doing is you are motivating them, and then that has a significant effect. I think if you fix their leg, but mentally they don't feel that people care about them, and they have really improved, and that happens when like as a cardiology fellow, I worked, I would spend time at our Foxborough cardiac rehab, and the terrific job that you do with motivating these patients, it has profound effect on them. So, yeah.
Somebody else?
The question is, and I don't know how to word it. I know you talked about checking the blood pressure with the ABI, but how do you differentiate between pain, say that came back from normal or slightly decreased? How do you differentiate pain in the thigh from being cardiovascular PAD versus overtraining or versus muscular? Because people say, "Oh, I get pain in my thigh all the time from when I walk." You're thinking Achilles, you're thinking quads, you're thinking versus cardiovascular. Is there a way to?
Absolutely, that's a very important question. Yeah. So the question was that the muscle pain can happen because of just exercising a lot, or it could be because of a PAD. Like, for example, when I run on a treadmill, after a few minutes, I mean, it starts aching. So it's all, when we exercise, there is accumulation of lactic acid, and which causes pain. So it is completely normal. So the important thing here is how much of exertion causes pain, right? So if you started having pain after walking or exerting for maybe, let's see, if we are talking about walking for, like walking never should cause pain, but let's think about someone walks on a treadmill. But afterwards, just exercising for 3 minutes or 5 minutes, and again, a lot of that depends upon someone's age. If someone is younger, if they say that, oh, just by running on a treadmill for like 5 minutes or 6 minutes, it's still aching, then in that case, you should be concerned. But if, for example, older people, if they say, oh, with just 2 minutes of walking or something, then it starts hurting. So again, you have to look at the patient overall, what their muscle buildup is and all that. So if you think that they haven't put in that much an effort, or they haven't been through that grind of exercise and it's aching, then in that case I would be worried about PAD. And just one point before I take your question, I would want to add. So the current guidelines also, because again, checking an ABI, ankle brachial index, it's just a non-invasive test that anyone can do it very easily. The current guidelines recommends for anyone who is more than 50 and they have any one cardiovascular risk factor, either you smoke or you're diabetic, if you have heart disease, you should be checking it routinely. So it won't be bad to think of that high-risk population and test it in them. Yeah. Please.
Centers looking to start a PAD program. Can you explain the referral process, how that gets initiated, like what's included in the referral to the rehab, and then how is it cleared through by CMS?
Yeah, exactly. No, I think that's a very important question. So the question was that how the referral process works to a facility, and how does the CMS reimbursement process works. Now, again, since we are still learning, and mainly because it was just a reimbursed, it was just approved for reimbursement, I'll share with you what our Brigham experience and how we are uptaking this. So number one is that we have to recognize that PAD is a problem and it causes these symptoms, and that exercise training helps. How would that happen? That would happen through education. From the physician side, we are doing that by writing a lot of papers on that. When I go to our cardiology and vascular medicine conferences, we are talking a lot about this. But then, as you know, a lot of these patients, they're not seeing a cardiologist or a vascular medicine specialist, they see primary care physician. So now from our side, the next step is we're reaching out to primary care physicians, telling them to look out for PAD, and if they find out that they have PAD, to refer those patients to us, or when we send it back to them, to refer them to exercise therapy. Now, for example, at Brigham, we have Epic. So now, again, pretty much most centers would have electronic health records. So you need to have that. Like, for example, in the past, we had it for cardiac rehab. Then I would put in an order for cardiac rehab. It would ask us, what is the indication? Are there any contraindications? Add a comment about what needs to be done or what you need to be careful about. At times, as you know, prior to cardiac rehab, you need to do a baseline exercise treadmill test before you send it to them. But there is no such criteria for PAD right now. But again, if a patient is having symptoms at rest, so as a physician, I should not be referring those patients to you for exercise therapy. So what we have done at Brigham now is we have made that change in our electronic health record. So there is a term when you type called SET, which means supervised exercise training. Then in that case, it would open up that tab, and then it would ask questions about, from us physicians, how much can the patient exercise now? So that when you are opening that order, you can, instead of, at times patients might not give you specific information. So you can just, even before you see the patient, you get it from us that, oh, this patient can walk this much. These are the patient's limitations. And then it would ask us, has the patient ever been revascularized? Is revascularization planned for the patient? And that just helps us build a relationship between us and then clinical exercise physiologists, so that you know what the plan is. And then after that, the question we ask is, has the patient ever been through these kind of training programs? And then I would say yes or no. Most patient the answer is no. And then after that, these patients, then right now what we are doing at the Brigham is that, again, we don't want to segregate cardiac rehab from, and make a completely different PAD exercise program, because we think they're all part of the same program. So we want, and also it will take a lot of investment from just opening up a separate PAD program. And I think our overall goal is cardiovascular well-being. So the vascular part here is the PAD too. So they go to our cardiac rehab, and then over there, what we have done is that these patients come and see our clinical exercise physiologists who have been doing cardiac rehab. And then, for now, every center might have a different protocol, and I'm happy to, I can email Sam what the protocol is at the Brigham, and you can share it with everyone who's attending here, what that is. And what that involves is patients come in, they would sit in a class with patients who are there for cardiac rehab, and then you talk about overall cardiovascular well-being and all the other things, and then they would go on the treadmill, and then they would go through treadmill protocol, and then we get feedback from you regarding how the patient is doing, and then we are able to chart how much their distance is improving. We completely depend on you to see if you think this is a patient who would improve. Now, again, a lot of these patients, at times what might happen is they have bad arthritis, and because of that, they are not improving, even though we have done a terrific job with exercise training. So if they're not improving, then they're not someone who would benefit from an extended therapy. But again, we look up to you for that advice. Now, again, this field is going to evolve, and this will evolve with, I think, cardiologists, vascular medicine specialists, clinical exercise physiologists, people who run these cardiac rehab, outpatient rehabs, and all that. So I would all stay tuned, and you should also think about, I think your organization here should think about what are the novel ways that, how we can improve so that it is in the best interest of the payers, regulators, physicians, and most importantly for patients.
Let's check and see if there's any online questions.
Okay, so
Greg,
let's check.
Let's check.
Yeah, Greg can help us. Yeah.
You take one more quick question if there's any more from the audience. Oh, quick question. Paul?
I'm curious how much you thought improvements in collateral circulation affects the quality of life of the patient. Collateral circulation exercise incorporated
Yes, so I think, okay, and there are questions that, yeah. No, but I think that's a very important question. So one, interestingly, what I have learned is that compared to the cardiovascular bed, the lower extremity is very good with forming collaterals. Now, it is because probably there's something unique about the muscles and whatnot. So certainly, yes, and that is what we think really exercise may be. Again, because exercise doesn't help you open up those major blockages, and we have had patients who exercise, and then when we are doing, again, if their symptoms hasn't improved to where it would be, then we would take them for revascularization, and we do have pictures before and after. And what we have seen for many patients, there are some collaterals that are formed, but we do believe that the main mechanism through which it is acting is by helping new collateral forms. And with that, I mean not the big arteries or the medium-sized arteries, but really the small, tiny capillaries. So I think exercise plays an important role by doing that.
Let me just take one of them that we haven't covered yet.
Yeah, and I'll be happy to take it offline too. Yeah. Okay. So, okay, yes. So what the question was that what would you suggest as an upper heart rate limit or target heart rate for patients who have PAD? We're being asked that I have looked at several publications regarding PAD and exercise and cannot find heart rate guideline while developing our cardiac rehab PAD program. Once a patient is in our PAD program, please describe what symptom or sign would warrant contacting the patient's referring MD. I think that's a great point. That's a terrific question. Did you guys, I think everyone got that question here. Yeah. So one, when we are doing exercise for PAD, there is no heart rate goal. And our goal over here is mainly to monitor or watch out for when they start developing symptoms, and let patient be the judge of how far they can go. We stop when the patient, they start developing symptoms that they can't tolerate anymore, or their symptoms happen. For example, you exercise a patient and then they stop, and then you want to try again, but they say that I'm not having symptoms at rest. In that case, I wouldn't go ahead and do any more, and that should be the time to call the physicians. Now it happens as it happens for cardiac rehab. I've never really seen it that patients, like, as you know, the maximal heart rate, predicted heart rate is 220 minus your age, and then that never happens here, because these patients, if they can exercise that much, then in that case you never would have to go through that form of exercise training. But to think about a PAD patient, since they're at a high risk of cardiovascular disease, one, of course, resting pain, or if you notice that again their legs are developing, they're becoming pale, or they're becoming blue, again rarely happens, because at that time they would have symptoms, something to think about. Or if they start complaining to you, I've never walked, but today I started walking and I'm having chest pain now and all that. So as you would do for a cardiac rehab patient, for them completely, I think makes sense to contact their referring physicians.
Okay, I think because of time, we're going to have to move on. Thank you very much.
Thank you.